introduce now Elisabetta Degasperi, who is a medical doctor and acting as a hepatologist in the Division of Gastroenterology and Hepatology in the University Hospital in Milan. She studies in Milan, and she received also a PhD in clinical experimental medicine. She is quite active in hepatitis B and delta clinical research, and she's involved in many phase 1, 2, and 3 and post-marketing studies in both chronic hepatitis B and chronic hepatitis delta. But she was also very importantly engaged in hepatitis C a few years ago. We all know her effort there as well. We followed up that. And Elisabetta, is to you to talk about diagnostics in challenges in HBV diagnosis. Is to you.
So thank you. First of all, I'd like to thank the organizers for the invitation. Apologies for some connection problems. And my topic today is challenges in HBV diagnosis. In the next 15 minutes, I will cover, next slide, please, 3 main challenges. Think about Delta, test for Delta, and resource-limited settings. Next, please. So the first challenge is think about Delta. We have seen the WHO recommendations. We all know that the recommendations for HBV screening differ according to international societies, while the EASL and the APASL recommend universal screening of all HBs antigen carriers. The American Association for the Study of Liver Disease only recommends screening in patients with specific risk factors that listed here. And we have heard from Niklas that rates of HBV screening in real-life practice are still low, with some virtuous exceptions, such as the Swedish study. Next, please. So the first challenge is how to increase diagnosis rates. We have heard the benefits of reflex testing, that is the automatic reflex testing of all HBV antigen carriers. We have heard some experience, the Spanish study already presented by Niklas, and also on the right, a single-center Italian study that evaluated 1 year of reflex testing compared to a pre-reflex testing era. And of course, as you can see, the rates of HBV diagnosis peaked up to 90, 100%. However, please note that in the Spanish study, more than 60% of patients had no definite risk factors for Delta, so they would have been missed by a targeted screening strategy. Next slide, please. So the next question is the reflex testing also beneficial in terms of liver-related outcomes and affordable? So on the left, you can see a Spanish modeling analysis recently published, evaluating the cost effectiveness and also the impact on liver-related outcomes of the anti-HBV reflex testing. And as you can see, the implementation of reflex testing is expected to lead to a significant decrease in cases of liver cirrhosis, decompensated cirrhosis, HCC, and also liver-related death. On the right, a recently published analysis from the Polaris Observatory Group try to calculate the affordability for healthcare systems of anti-HBV reflex testing. They propose also double reflex testing, both anti-HBV and also HBV RNA. So they calculated that giving 2 million new HBV diagnoses per year, given a prevalence of HBV worldwide approximately 5%, so 89,000 people who need annual HBV RNA testing. And so this strategy will not overburden healthcare systems. So next slide, please. So the second challenge is a test for Delta. So what is the current performance of available anti-HBV assays? These are the results of a national quality control study held in France for the diagnosis of HBV infection. It involved 23 labs evaluating both the anti-Delta total antibodies and also the IgM antibodies. So on the right, you can see the results. So for the total anti-HBV, labs were concordant for more than 80% of participating labs, and discrepancies were only seen for weak positive samples. The concordance rates for anti-HBV IgM were lower. However, during the study period, there were a decreasing number of labs using the anti-delta IgM due to the availability of more specific HBV RNA assays. Next, so we have also some more faster and more specific anti-delta assays on development. Here I put two examples. One is a collaborative study held across US, Europe, and Africa, evaluating a new assay for IgG antibodies, the Architect assay, that was compared to the reference standards liaison test. And as you can see, the Architect, the new test, outperformed the liaison for specificity, sensitivity, and predictive values, and best performed on the low viral load samples. If you see the yellow square, so the Architect missed only 3 samples with low viremia compared to 6 samples missed by the liaison test. On the right, a single-center Mongolian study tried to evaluate a new sensitive ELISA assay that is using a new technology for antigen immobilization that should grant for increased specificity compared to the traditional physical absorption method. And also in this case, the sensitivity and specificity were optimal. And please note that this assay had a low turnaround time, only 30 minutes. So next slide. However, we should also be aware that there are some cases of active infection in patients with anti-delta negative antibodies. These are the results of the Prolifica project held in Gambia. They tested more than 700 HBs antigen carriers by both a point-of-care testing and also the diazorin test. And they found 28 patients with positive HBV RNA and negative antibodies, so 4% active HBV infection despite seronegativity. On the right, you can see the levels of viremia in these 28 patients. So you can see that they were very, very high, some patients with 6 logs of viremia. Of course, we cannot say that maybe these patients were in the window phase of early infection. However, so the message for clinicians is always perform the HBV RNA in case of strong clinical suspicion of HBV infection, so elevated ALT and low HBV DNA. So next slide. So we have heard about sero prevalence and also performance of a serology test. How about the HBV RNA quantification, so the virology? Here, the field is more complicated as we have many available assays. This is only a partial list. As you can see, there are many tests with different lower detection limits, lower quantification limits, some tests reporting results in copies per ml, some others in units per ml. Some of them are research use only, other are certified. And please remember that the WHO international standard for HBV is obtained only for genotype 1 patients. So next slide. So how can we compare these very heterogeneous assays? I will show you two studies. The first study that was presented at the last Delta Cure meeting tried to compare 7 different assays that are listed here, 2 from the Altona kits, 2 from the Eurobioplex, and 3 different versions of the Robogene commercial kit. Overall, as you can see on the left, these assays reported similar qualitative and quantitative performance. However, the Eurobioplex kit systematically overestimated by approximately 1 log the viremia. So you can see the light gray crosses, and was withdrawn from the market last year. And we had also some quantification problems on some strains of African HBV genotypes for the Altona kits. The next slide, the next study is the multi-center quality control study held in Italy, involving 30 centers. They evaluated 6 commercial assays for HBV RNA and 3 in-house assays that are listed here. And again, also in these cases, heterogeneity was higher and especially concerning lower detection limits. And most assays had a drop in performances in case of low viremia below 1,000. And only the Robogene and the Altona assays had the best performances in very low viremias below 100. This study was presented at the last EASL Congress. So we have seen the complexity in HDV RNA quantification across assays. However, to make things more complicated, next slide, please. I have to say that also HDV RNA quantification differs according to, in the same assay, according to different technologies and different extraction methods. This single-center Italian study recently published evaluated more than 200 samples from more than 157 patients, some of them bulevirtide treated. And we use the Robogene assay, but two different extraction methods, the manual and also the automated extraction. So if you can see on the left, the manual extraction in gray, dark blue, reported higher HDV RNA values, more than 1 log, than the automated extraction. And this was true both for untreated patients and also for treated patients during treatment, resulting also in different rates of HDV RNA undetectability on therapy. So the message is here, so don't get crazy. However, with all these assays, all the technology, all the extraction methods, however, please use always the same assay to monitor your patients in order to have the most reproducible results. So coming to the last part of the presentation, next slide. Some words about the resource-limited settings. We have many promising technologies for low-income countries, and this is one example, the dry blood spot technology. Dry blood spots can be stored at room temperatures for 2 weeks, so they are very user-friendly. In this French study presented in the last year Delta Cure meetings, they tried to validate a specific DBS cutoff for anti-HDV detection, and this turned up to be 100% specific compared to a commercial assay. Then they evaluated the qualitative detection of HDV RNA positive samples, and here again the sensitivity was optimal, and only low viral load samples were not detected. And now the prospective part with the whole blood on the DBS is ongoing. The second example I want to show you, next slide, please, is the rapid test for HDV. The rapid diagnostic tests look like very similar to some other rapid tests like COVID. They have only 5 minutes incubation period, and in this collaborative study, more than 200 samples were tested by the rapid diagnostic tests, and results were compared to the reference standard ELISA test and also in the in-house HDV RNA assay. And as you can see, there was 100% agreement between the rapid test and the ELISA test. So finally, we have also some technologies for the HDV RNA assay. Next slide, please. And this is one example, the LAMP PCR. LAMP stands for loop-mediated isothermal amplification PCR. It is a low-cost assay that doesn't need for specialized equipment. It has a visual colorimetric detection, so pink stands for negative and yellow for positive. And in this study, these samples were also retested with the standard quantitative PCR. And as you can see, there was 100% concordance on HDV RNA negative samples and just 1 false negative among HDV RNA positive samples. And this assay had a very low low detection, lower limit of detection. So to conclude, the next slide. We have seen that the HDV screening in HBs antigen carriers is currently underperformed in clinical practice despite international recommendation. So the reflex testing, both anti-HDV and also the double reflex testing, could be a helpful tool to maximize diagnosis. Anti-HDV is the first screening tool. However, please remember to perform HDV RNA assessment in case of clinical suspicion. Quantification of HDV RNA may significantly differ according to different assays, and also within the same assay according to different extraction methods. And this heterogeneity prevents comparability, so please use always the same assay to monitor your patients. And finally, rapid user-friendly assays are in development for resource-limited settings. And with this, I would like to thank you for the attention, and I'm happy to receive questions. Thank you.